Okay, so this is going to be a lecture on the assessment of the musculoskeletal system. Remembering that the musculoskeletal system is important for normal growth and development in the child, and that strong, healthy bones and muscles allow for that normal linear growth, as well as gross and fine motor physical activity, body movement, and play. An assessment of the musculoskeletal system requires a very good knowledge of gross and fine motor developmental milestones and the impact that physical growth has on a child's body image and self-esteem. So it's all really important for you to really have a good grasp on. Hence the need for this lecture in this class. Excellent pediatric musculoskeletal assessment skills are essential, particularly when you are doing assessments on children for injuries. And looking for things like repetitive use injuries, epiphyseal plate fractures, and then the unfortunate intentional injuries inflicted on children. Those need immediate recognition and appropriate referrals, as you know, of course. Okay, so remembering that there are 206 bones in the body, there are 3 types of joints and more than 600 muscles in the body. The primary functions of the musculoskeletal system are to support and protect the inner structures of the body and allow for mobility. The musculoskeletal system is made up of bones, joints, ligaments, cartilage, muscles, and tendons. And these structures allow for various movements and serve as protectors and many other things. So we know also that when you do assessment, as you'll learn through this lecture, of the musculoskeletal system, you're going to be doing less stuff like auscultation. Most of musculoskeletal system is going to be observing and then with some palpation, but you won't do as much auscultation or percussion on the musculoskeletal system. Also, we remember when we talk about the musculoskeletal system, we're talking about dividing it into the spine, the upper extremities, and the lower extremities, and we'll get more into that in the next section. So first, before we go there, let's talk a little bit about what are the differences between a pediatric musculoskeletal system and an adult musculoskeletal system. Differences are that in children, the bones are not fully ossified or completely done growing until children are adults. The periosteum, or that outer coating of the children's bones, the outer layer, I should say, is thicker than adults, which means that they are less likely to have those open fractures, and their fractures are less likely to be displacing or displaced, and that's compared to adults who have similar fractures. Children's long bones are more dense and more porous than those of adults. Children's ligaments are stronger typically, and that means that they are less likely to get ligamentous injuries than adults are. There's increased compliance in children's bones, which means they're kind of more bendable, they're more flexible, which means they bow more than they do fracture when they're subjected to stress, which is a good thing because we don't get as many fractures. We do get, other types of injuries in children. But they are prone to repetitive use injuries and epiphyseal plate fractures, and then because of their developmental youth, intentional injuries by others who are stronger than them. All right, starting with the skeletal system overall, remembering I just went over this with you, but these are the different parts that make up a skeletal system. The bones, the joints, the muscles, and then the axial skeleton, the appendicular skeleton, and the joints. So we're going to talk about each of those kind of broken down. First, we'll start with the axial skeleton. The axial skeleton is made up of the vertebral column, the sternum, the ribs, and the skull. And this is not the greatest picture that talks about the axial skeleton, since this includes other bones in it, but it gives you another good idea of the axial skeleton. So starting with the spine, the vertebral column or the spine consists of 33 bones called the vertebra. They connect together to form a flexible column, and that spine then is divided into 4 different curves. You have the cervical curve, the thoracic curve, the lumbar, and the sacral curve, and we look at those when we look at doing our scoliosis assessment, and also when we're doing our assessment of children for other things, because there can be more than the scoliotic curve. There can be other types of curves as well, in curves that are not typical. Individual vertebrae are further divided into their anatomic region and their number, remembering that there are 7 cervical, 12 thoracic, 5 lumbar, and 5 fused sacral vertebrae. And then the coccyx, which is the tailbone, which is made up of 3 or 4 fused vertebrae. The processes, the spinous processes of the vertebrae, they begin at the 7th cervical vertebrae and continue down into the sacrum. And the thoracic thoracic spine articulates with the rib cage, and that makes up that protective area for all of those vulnerable organs in your thoracic cavity. The lumbar vertebrae they are the largest. They're at your lower back, and they take on most of that heavy weight-bearing portion of your spine that allows you to flex and extend. And finally, the sacrum fuses those 5 vertebrae, and it articulates with the ilium at the sacroiliac joint, and that connects your body to your spinal cord to the pelvis. It's a strong joint joined by ligaments, allows for the movements of standing, walking, turning, and sitting. And then finally, your coccyx, which articulates with the sacrum, and inside of the vertebral column is the spinal cord. And moving on to the next is the appendicular skeleton. The appendicular skeleton is comprised of 126 bones, including the arms, the legs, and the hips. In addition to giving structure to the body, the bones also produce those red blood cells, those white blood cells, and they also store calcium, phosphorus, and release those minerals back into the bloodstream as needed to maintain homeostasis, right? So it's more than just function. It also has that vascular component. The skeletal system includes 5 major bone types, and their names reflect the shape of the bone. So we have the long bone, which is your humerus and your femur. We have your short bones, the carpals of your fingers and the tarsals of your toes. The flat bones, the skull, the sternum. Irregular bones like the vertebra. And the sesamoid bones, which are bones that are embedded by tendons like your patella. The long bones are especially important for children because their structure and makeup includes a rounded end termed the epiphysis and a long shaft called the diaphysis. And between these two portions of the bone is the metaphysis and the part of the bone that grows during childhood. Because remember, the bone grows from that growth plate outward, not from the middle of not the middle of the long bone, but at the ends of the long bone. Okay, a little bit more about this appendicular skeleton. There are 2 clavicles. Each one articulates with the sternum and the scapula. The scapula and the upper extremities are supported by ligaments. Those ligaments are the trapezoid and the conoid. The scapula is attached by muscles to the thoracic cage. It kind of floats back there, right? It doesn't articulate in a joint area. It's more held together by ligaments and muscles. And movement is possible between the scapula and the thorax and between the scapula and the humerus because of those structures that allow it to be so flexible. That's why you can get so much range of motion out of your shoulder, because it kind of just dangles there. The humerus extends from the shoulder to the elbow. The structures of the shoulder are in your book. You can take a peek at the pictures there that kind of remind you of how it's all put together. The elbow is made up of the humerus, the radius, and the ulna. And the ulna, as you remember from anatomy and physiology back in the day, is larger than the radius and runs from the elbow to the wrist on the lateral side, and the radius is on the medial side. The bony prominence of the elbow is the medial epicondyle, which along with what's called the lateral condyle, forms the area where the humerus and the surface of the ulna come together. You can also take a peek in your book to look at the bones of the elbow. And getting down to the wrist, we have the distal end of the radius bone connects with the distal end of the ulna to create what are the proximal portion of the wrist, right? So it's where the wrist bones come together with the lower arm bone. There are 8 carpal bones. They are all bound by ligaments. Remember, they kind of are held together, but it gives a lot of range of motion, their ability to move around in there. And so then the hand and the fingers include the 8 carpals of the wrist, 5 metacarpals of the palm, and 12 phalanges of the fingers. And each finger contains 3 phalanges. The thumb is composed of 1 metacarpal bone and 2 phalanges. Moving on down in that appendicular skeleton to the pelvis and the lower extremities. And remember that the pelvis is made up of hip bones, the sacrum, and the coccyx. Each bone is divided into parts, the ilium, the ischium, and the symphysis pubis. And then the femur, which is the longest and strongest bone in the body, extends from that hip bone area, from the hip, down to the knee. And the strongest ligament in the body, the iliofemoral ligament, connects the femur to the ilium. So it's strong, but it allows for that movement. But when you have your hip, there is some range of motion limitations to the hip compared to the shoulder, because the hip bone, is that ball and socket joint that doesn't allow for it to do that 360 degree movement. The connection of the femur, the tibia, and the patella forms what's the knee joint. And this connects to the distal or distant end of the femur and the proximal end of the tibia. And then the tibia and the fibula are the 2 shin bones, the lower leg bones. The tibia is larger than the fibula, and they extend down into the ankle. And at the ankle, they connect with the talus, which is the ankle bone, which connects with the calcaneus, which is the heel. There are 5 tarsals, 3 metatarsals, and there are the 2 phalanges that make up the great toe. 3 phalanges make up each of the smaller toes, and you can look in your book for pictures of the knees and of the bones and the foot. So we're going to go back over here and talk a little bit more about the growth plate, right? The growth plate is a bit weak. It's structurally weak because it's made up of cartilage, and it doesn't fully ossify until the child is in early adulthood. Because of this, traumatic injury or shearing forces or any type of epiphyseal fracture can result in what's called early or incomplete closure of the growth plate, which can cause problems as the child continues to grow. Limb deformity, shortening of the bones, or arresting of growth altogether. So we want to take a look at, when you're assessing a child, where is the fracture potentially at? They're most likely to get injured in those areas of the body where the growth plate is at. So I'll let you take a peek at each of these slides for all of the great information. The growth plates usually close near the end of puberty. So for girls around age 13, 14, 15, sometimes 16, 17, 18 if they have late menses and late puberty. And for boys, it's typically older because boys tend to go through puberty a little bit later. And as you can see here, this is just an X-ray depiction of the growth plate. Okay, so bone tissue formation, which is also called osteogenesis, is a continuous process occurring as cells, which are called osteoblasts, build new bone tissue while they also destroy or reabsorb old bone tissue. And in childhood and adolescence, bone growth exceeds reabsorption. But in early adulthood, these processes are way more balanced. And then beginning in middle age, bone tissue reabsorption outpaces bone growth. So that's why we have osteoporosis as an issue. Because osteogenesis occurs more rapidly in children, fractured bones in children heal more rapidly than those in adults. That's why kids can have an injury and kind of get over it more readily than adults can. And this slide also tells you what we talked about a little bit earlier about the other things that bones bring us other than just structure and support. Those blood cell formation, balance for that calcium, phosphorus, and releasing those minerals into the bloodstream. All right, we'll start talking a little bit here about joints. Joints are the places at which bones come together. Joints are held together by what are called ligaments and cushioned by cartilage. Ligaments are strong, fibrous cords of connective tissue that bind the joints firmly together. All synovial joints include ligaments. Cartilage is an avascular tissue that receives its nutrients from synovial fluid through diffusion. Cartilage is a firm but flexible tissue that cushions the joints and helps soften impact. There are three types of joints. There's the synovial, the cartilaginous, and the fibrous. Synovial joints are the most common joint type, and they're also the most mobile. Components of these joints include the joint capsule, the synovial membrane, the articular cartilage, and the synovial cavity. This cavity is filled with that synovial fluid that lubricates the joint and enhances that movement. And you can see a picture of this, the hip joint depicted, that shows you the components of the synovial joint. There are 6 types of synovial joints in the body, and the examples are carpals of the wrists, the elbow, the wrists themselves, the thumbs, the shoulder, the knee, the hip joints. In synovial joints, cartilage covers the surface of the bones where they meet. And finally, in cartilaginous joints, 2 bones are connected with cartilage, which allows for only some slight movement. The pubic bone juncture and the joint between the manubrium and the sternum are examples of the cartilaginous joints. They move, they are flexible, but they don't really move in the same way that synovial joints move. They're more allow you to get into different positions and have babies. Fibrous joints are the least mobile of the 3 types of joints. These joints tightly connect the articular surfaces of 2 bones, and it's a very dense connective tissue, and those would be the cranial sutures on the infant's skull. And you can see more about this in your textbook, of course. Okay, so we're going to talk a little bit about the movement and the skeletal positions of different joints, right? So we have here on the 3 different types of movements. We have different skeletal positions. We have flexion, which is a decrease in the angle of the joint. We have extension, which is an increase in the angle of the joint. Adduction, which is movement toward the midline. Abduction, which is movement away from the midline. Rotation, which is movement around a central axis. Inversion, movement of an extremity towards the body. And eversion, movement of the away from the body. You can see a chart of these different movements and their descriptions in your textbook as well. All right, we'll talk a little bit about muscles and tendons now. Muscles are tissues that are composed of fibers or bundles of cells. They vary in size, shape, and arrangement. The muscles contract to move bones, while the joints allow for the movement to occur. There are 3 types of muscles in the body: skeletal, smooth, and cardiac. Skeletal muscles are voluntary, striated, and arranged in bundles. They are things like the triceps, the biceps, the quadriceps. Smooth muscles are non-striated. Those perform those involuntary involuntary movements such as like breathing, urinary tract movement, gastrointestinal system. And then there are cardiac muscles, which are specialized cells. They're striated involuntary. And tendons are firm, strong cords of the fibrous tissues that connect the muscles to the periosteum. During infancy, muscles comprise 25% of an infant's weight, but when we are adults, they are 40% of an adult's weight. And then as myelination proceeds, the growth of muscles, development of muscles, voluntary muscle control progresses. And muscle growth contributes greatly to the weight gain in childhood and to walking and weight bearing. Those both stimulate the growth of bones and of muscles. So the children that walk grow normally because the stimulation of the walking causes them to grow. So kids that are in a wheelchair or have less ability to move do not grow in the same way. Muscle growth continues into adolescence, with growth occurring more rapidly during this time because of the presence of sex hormones, particularly testosterone. And rapid muscle growth during this time can cause clumsiness, increasing an adolescent's risk for injury. We think of 3-year-olds who are growing as being a risk of injury because of their growth, but really it's also in adolescence. So looking a little bit at cultural, ethnic, and racial considerations. Some musculoskeletal conditions occur more frequently in certain racial or ethnic groups depending on their practices, the environment in which they live, their socioeconomic factors, or also genetics. So we have things like Blount's disease, which is also called tibia vara. It occurs most commonly in Scandinavian and overweight African American children. Caucasian children have a high incidence of developmental dysplasia of the hip, DDH. That's in infancy, as do indigenous North American people. Those are people who keep their newborns tightly swaddled because of the cold, which keeps their hips in that adduction close to the body. And then DDH can also have a genetic component. And then the Talipes equinovarus, which is a true clubfoot, which interestingly my grandmother had, is most common in Polynesian groups, particularly those in Tongan people, which we are not, which is interesting though, and it can happen. So take a peek at this slide. It's a lot of words on here, but I kind of just went over each of them. And you'll read in your book a little bit more about those cultural and ethnic differences. Moving right along here into history and physical. Knowing that musculoskeletal problems in children can be acute or chronic, and that the reasons for them coming into the health office guides you in deciding what kind of data you need to collect for them. What is the reason that they're being assessed, whether it's for an injury, an episodic need in your office, or whether you're doing a health and history and physical for an IEP. Maybe you have a child with osteogenesis imperfecta or somebody with muscular dystrophy, a known problem, or if you're trying to determine what the problem is. So you will want to know some stuff about the child, remembering that your examination varies depending on their age. If they're a little preschooler, you're going to do things differently than you are for like a 15-year-old. And what you're looking for are, one of the things you're looking for are, were those milestones met? Or were they slower to meet those? Did they meet them? Yes, but then were they slower to meet them? And that could be a condition that you need to look out for. Some conditions, as you see here, the leg calve perthis disease typically develops in boys from 4 to 10 years old. So they may be typically developing until they get into that preschool age, and then things start to change a little bit. So you want to know a little bit about their perinatal and their neonatal, and then also their growth from birth on. So you want to take a peek at that when you're asking mom and dad questions or guardians questions. You also want to look at any types of neglect signs. You want to look at whether or not their delays have resulted from something like neglect, or if they've been harmed in any way. You want to look at whether or not you do a prenatal history. Depends on the age of the child. If you have a young child, maybe you're doing a toddler program or a preschool program, then you might want to think about a prenatal history. You might also just want to look at a prenatal history if somebody if they have a positional clubfoot, or if they have DDH. You might want to know about their history during their birth, if the child had some kind of problem during the birth event. Then you also want to look at that review of systems, right? You want to look for those cafe au lait marks, asking about whether or not the child has any of those cafe au lait marks or the NEVI. Those can be suggestive of neurofibromatosis or other types of neurological problems. You're going to ask about any congenital heart defects, which can cause poor growth, which would then rule out some musculoskeletal types of things. Poorly controlled asthma or cystic fibrosis, which can also cause that poor growth, to try and rule out, musculoskeletal growth issues. Then any other types of gastrointestinal things like that absorption issues, again, the growth issue. You look for hemophilia, which can cause that bruising. You're going to ask about hemophilia, and that can cause that bruising. That gives you clues that it's maybe not musculoskeletal, it's maybe hemophilia or sickle cell disease, which can cause the pain that you might be looking for. Any kind of infectious diseases like tuberculosis, you're going to ask about that, which can infect the spine and the joints. You're going to ask about any osteomyelitis history, any Lyme disease, because that is a musculoskeletal disease. It can have some arthritic type of symptoms. And then you're going to ask about things like torticollis when they were a child. You're going to ask about metabolic problems like obesity. You're going to ask about, again, back to musculoskeletal, you're going to ask about, did they have any bow-leggedness? Were they ever diagnosed with flat feet? Have they ever had problems with limited range of motion? Kind of just go down your list. Have they been diagnosed with Marfan syndrome, etc.? So you'll go down each of those, and they all are meaningful because they help you to rule out the problems. Remember, we're still in the review of systems where we're not really looking at the child yet in physical assessment. We're still looking at asking the questions for the history. You also want to talk about with the parents and the guardian any types of injuries the child has sustained, fractures, dislocations, subluxations, sprains or strains. Fractured clavicles are common in neonates and young children. Sports-related injuries should be noted. Anything that things that might have been in the growth plate. Looking at the child's age as you do this, looking at the potential for that neglect or harm from the guardian or someone in their realm. You're also going to look a little bit at some of these congenital musculoskeletal issues that might arise or be noted. Things like the torticollis, which is muscle contraction on the neck, which can be from birth trauma or that sternocleidomastoid muscle having issues neurologically or musculoskeletally, or the child is left, laying for too long. Polydactyly, that extra digit on the hand or the foot, it might have been removed. You might want to ask about that. You also will want to look for those congenital musculoskeletal deformities we talked about with DDH and clubfoot. And so what are some of the important questions that you would need to ask when you're talking about a history? So if it's an injury or an episodic type of assessment that you're taking, child comes into the health office or, comes back from being having had an injury, you want to talk a little bit about the history of the present illness. We haven't really talked a lot about history of the present illness in this class because we're typically talking about assessments you'll be doing for IEPs. But when a child comes into the health office, you're going to ask, when did it start? Was it due to an injury? Have you been sick recently? Is it from sports? Were you working out too hard? Does anything make it better? What makes it worse? Does it wake you up? How severe, 0 to 10, or use the Wong facial features? What other scale you can find for children? Do they take medications? How does that help or not? And as you can see in your book, you'll notice that in table 21.4, there's a chart of the history of the present illness for you to use. And each one of them includes onset. Each one includes recent injury. And then from there, you have different types of questions depending on where the complaint is. So You'll always want to know when it started. You always want to know whether it was due to an injury. And then the variations depend on the location. And then you'll be able to look at in the chart a differential diagnosis or cause that might be arising from that problem. All right, so in children, you also want to look at back pain. Is it from backpack or fever? Hip pain? Is it from fever or upper respiratory? Is it from knee pain, swelling, leg pain, limited range of motion? And then you're going to start looking at then your physical examination. Right, so the physical exam is achieved through inspection and palpation. You focus on the general configuration of the child, how they look, to the symmetry and length of their extremities, any deformities, any masses, any crepitus or point tenderness, like a place that hurts. You're going to always take, of course, that developmental approach to the examination because of their development. It matters like what age they are and how you go about things. The things that you will potentially need for a musculoskeletal examination would be a reflex hammer. And you might want to have a scoliometer if you're going to do a scoliosis assessment, and then tape measure if you're going to measure sizes. As I mentioned earlier, the child's age and developmental level are a major consideration when you're looking at examining the musculoskeletal system. It's the way and the manner in which you conduct it and how you interpret the findings. So, of course, most, or if not all of you, are not assessing infants. So with infants, you would just look at them move and make sure their body parts move, and then you would do some range of motion, some passive range of motion with them. But toddlers can be asked to play games like Simon Says, and you can have them touch their nose or their knees or bend over or follow the leader. And then children older than toddlers, they can follow commands and instructions. So they're a little bit easier to assess. So first thing you're going to do is you're going to observe. You're going to look at the child. You're going to enter the room or you're with them in the room, and you're going to look if there's any spontaneous motor activity. You're going to see them, how they're sitting, how they're standing, noting if they move around the room, what's their range of motion, what's their posture like, are there any obvious deformities, anything that you should note. Is their head in good alignment with their shoulder and hips as they're standing up? That kind of thing. So this slide gives you a good overview of what you'll be just kind of observing for. So you would need to assess their gait. You're looking for the normal gait cycle, which is described in your book, remembering that the health of the child's joints and muscles affects their gait, and that conditions like juvenile rheumatoid arthritis, muscular dystrophy, and cerebral palsy affect gait, and that the child's age and developmental level influence how you assess their gait. So preschool children and older children, adolescents, are asked to walk across the room barefoot. Then you would ask them potentially to stoop down and pick something up, noting how they do that. You'll have them take large steps. You'll note their gait for balance. You'll note their ability to bear weight at all. You'll note whether they toe walk, whether they have knock-kneed or bow-legged, whether they toe in or they toe out. And remembering that until they're about 7 or 8 years old, a slight knock-knee is within normal limits. And if they have toe-in stance or walking or gait, that can be caused by a metatarsus adductus, internal tibial torsion, or femoral anteversion. So all musculoskeletal problems of the legs, which we don't go into too deeply here. But if you see that toeing in, you would want to know about whether or not they've had any of these things, or you potentially want to refer them out. And if the child can cooperate, you'll have them toe walk, toe heel, toe heel. I lied. Toe walk, on their toes across the room, and heel walk back. That assesses the strength of S1 and L4, their nerve roots, and note any abnormalities in their gait, just overall. You're looking for a limp. You're looking for a gait that helps them avoid pain. Of course, they don't want to. They might be doing something different than a normal gait to avoid pain, and whether or not they're scissoring, legs crossing, A limp is a symmetrical gait abnormality that can be caused by the shortening of a limb. So if they have a shorter limb, it can also be caused by muscle weakness or paralysis or pain. It could also be because of several other developmental or growth problems for the child. So you'll get that information in your history, and then as you look at them physically, you will note the two things for your differential diagnosis or for your conclusions that you draw. Next slide here is looking at knock-kneed bow legs. And then a little bit more about doing that differential diagnosis for a limping child. All right, so then when we're looking at the upper extremity assessment is inspection and palpation for equal length and symmetry and strength and spontaneous movements, swelling, pain, tenderness, and range of motion. You're also going to assess the muscles for size, strength, and tone, and any limb contractures will be noted during this part also. As I said before, in infants, you're just looking for movement at all. In older children, you're going to have them do kind of a range of motion. You're going to have them, you're going to look at their palms. You're going to have them turn their palms up and down, arms out and back, kind of a full range of motion of all of the different joints so that you can make sure that they are able to move their body appropriately. You'll note there's a possibility of Erb's palsy, which is the paralysis of the arm caused by injury to the upper group of the arm's main nerves, specifically the upper trunk C5 and C6 nerves. And this can happen in birth or in infants, and you can note it later on in their lives as they get older. You'll also look at whether or not their joints are tender or warm, which could note juvenile rheumatoid arthritis or other issues such as lupus or Lyme disease. You're going to look to see if they have symmetrical hands, but they're also whether they're painful, could be noted as sickle cell crisis. And then also looking for the possible signs of Marfan syndrome, which is an inherited disorder that affects the connective tissue. And it most commonly affects the heart, the eyes, the blood vessels, and the skeleton. This is a really important one for school nurses to know about because children can have some deficits and some issues with this, and you would want to for sure either know about a child and potentially have an emergency care plan for someone with Marfan syndrome. And you'll see that their legs are quite long. Many people have noted that they thought that the swimmer whose name escapes me at this very moment, but that he potentially had some signs of what could be Marfan syndrome. I think they ruled it out, but his arms go way down. They're longer than most people's arms, but that is a sign of Marfan syndrome as well. All right, so here's how we're going to assess our joints. We're going to assess upper extremity strength by having the child squeeze your fingers. You're going to assess range of motion by asking them to move their shoulders and shrug. You're going to have them bend and straighten at the elbow, and you're going to have them pronate and supinate their hands, make a fist, flex, extend, abduct, adduct the wrists, all of those good range of motion things. You're going to look for, and sometimes this can happen, but doesn't. You probably wouldn't see this in the school, but you could theoretically see it, and this might be something that you would see if you were in a clinic or an emergency room, which is the radial head subluxation, also known as nursemaid's elbow. That's a common upper extremity, and it's caused typically by lifting a child up by their arms. It can happen in a abuse situation. It can also happen in a I didn't mean to, and I was just who picks the child up by their arms, but someone who doesn't know that there's a possibility of injuring a child could also do that. So you could look for something like that if they are noting that they have no redness or swelling, tenderness or pain, and if they are well appearing, and they hold their arm close to their body and they're guarding it, but the forearm is pronated and the elbow is flexed. So you want to look for something like that, especially if they come into school in the morning saying that they hurt themselves. That would be unusual, I think. All right, so looking at the spine, we're going to assess for range of motion, congenital abnormalities, curvatures, and in a newborn and an infant, you'll look for pigmented areas, or in a small child, you'll look for those pigmented areas as they are possible indicators of spinal cord abnormalities. You probably wouldn't see infants very much, but you might see toddlers. And so that would be something to look for. The spine is inspected while the child stands in front of you. And obviously they will not be undressed in front of you unless you're still doing scoliosis screenings, in which case we used to have them undress and turn away from us. But you're going to look at their posture first. You're going to look that their head is in direct alignment with their midline of their sacrum. Think I'm on the wrong slide there. Sorry about that. You're going to look at the range of motion of the spine by asking them to bend forward, then side to side, then backward. They should have no pain or limitations in movement. And with them standing straight, you're going to look at their spine. You could pull up their shirt a little bit just to look at their spine from the back, from the side. You're going to look for any curvatures. You're going to look for lumbar lordosis, which is a convex curvature. Their butt sticks out. This is normal in toddlers and small children, so I wouldn't be too worried about it at that point. You're going to look for kyphosis, which is that side curvature, or a concave curvature of the thoracic spine. This can be caused by a meningeocele, or tumors of the spinal cord, or just by bad posture. So be looking for the indicators of those different things. You're going to look for unequal shoulder height, an uneven waistline, or any other rib humps that can indicate that they have scoliosis, which is that lateral curvature of the spine. Further assessment of scoliosis includes what's called the Adams test, of forward bending test. It's performed with the child or adolescent standing in front of you, facing away from you. Their feet are together, their knees are straight. You ask them to bend forward at the waist, head down, arms dangling, touch their toes. We don't really have them touch their toes. We kind of have them dangling, and I have them really relax their shoulders down because they're very rigid. They don't want to relax. They're afraid. They're very embarrassed. They don't like it. To get them to relax, get them in that neutral position, and then you inspect their spine for alignment, any deformity, curvatures, a visible hump, a visible lateral curvature of the spine, and a scapula that might stick up on one side more than the other. You can also use what's called a scoliometer to measure. You place it on the back of their spine as they're bent over, and doesn't necessarily agree one-to-one. It doesn't correspond one-to-one with the degrees of curvature, but it can be helpful in deciding whether or not to refer. And that would be 7 degrees, typically corresponds to the Cobb angle, which means that you would want to refer at about 7 degrees on the scoliometer. And in my practice, we used to do scoliosis screenings every year, and we did refer at the 7 degrees. And I do have a good friend whose daughter was diagnosed with scoliosis, and it was the school nurse, and they referred her. She did wear a brace for a long time. Another friend's daughter was referred by a school nurse, and she did end up having surgery for it. So it can be very meaningful, and I know we don't do it anymore, but we had a handful of students that we did send for referrals. One of the things to note is, though, that once they start their period, the girls who are diagnosed with this, their growth is slowing down and ending. And so catching it early is really, really important. So even doing it in 7th grade, as we used to do, was potentially not early enough. I know that my own child started her period and her slide down to finishing her growth earlier than that. And so by 7th grade, she might have been, pretty set in where she was. So catching this early is very, very important. All right, so we're going to talk a little bit about pain, hips. In older children, the hips are evaluated mainly for pain, swelling, redness, position, limited range of motion. Children should have full range of motion without any pain. Hip pain in an older child is always a concern, so please note that. And it requires immediate evaluation. So if they are having hip pain, they really need to be seen by somebody. Older children may be unable to bear weight and experience pain or resistance to movement with passive range of motion. That would be something that you would need to have them referred for. Redness, swelling, or point tenderness of the hip suggests a potential for an infection. Limited range of motion with decreased internal rotation suggests what this SCFE, which I always mess up, which is slipped capital femoral epiphysis or Blount's disease. This can happen in pre-adolescent and adolescent males and in children who are obese. So please note those things. We don't always see hip injuries or hip issues, but if you do, these are some of the things you want to look for. All right, so lower extremities and feet and ankles. The lower extremities are inspected and palpated for equal length, symmetry, spontaneous movement, strength, swelling, pain, tenderness, range of motion. They're also assessed for size, strength, and tone. Any limbs that have contractures, there should be no obvious swelling or deformities or any erythema. The lower limbs should be symmetrical and equal in length. And in older children, the limb length is evaluated with the child laying supine. Legs extended, legs aligned. Limb length and discrepancies can be caused by a number of different things, including cerebral palsy, scoliosis, or an early femoral fracture. Any lack of spontaneous movement can indicate pain or an underlying condition that might need to be seen by somebody. And what the examiner needs to test for is limb strength. You're going to ask the child to push firmly with the soles of their feet against the palms of your hands. Lower extremity strength should be firm. It should be equal. Unequal lower limb extremity strength can be caused by pain, hemiparesis, or paralysis, which hopefully we don't see. Pain, swelling, and tenderness in the lower extremities can be caused by a trauma or an infection or a tumor, leukemia, sickle cell disease, hemophilia, or other things. So do note that if you have any problems with them being able to have that equal lower limb strength, or if they have that pain, swelling, or tenderness in those lower extremities. Pain with plantar flexion can indicate Achilles tendonitis. Pain in the arch of the heel is plantar fasciitis, and both conditions are seen pretty frequently in our adolescent runners. So if you are a school nurse in a high school or you see a lot of athletic kids, that might be the cause of that pain that you see. All right, you're going to have the child stand straight, facing you, with their ankles together. Knees are inspected for contour, deformity, tenderness, warmth, redness, swelling, alignment, and range of motion. You're looking for the bow legs, which are normal in 3 to 4 year olds, until about 7 to 8 years old, in which case if you have the bow legs after that age group, it could be something caused by rickets, which we think, oh, rickets not around anymore, but you might have some socioeconomic issues that causes people to not go to the doctor and causes people to have diseases that we don't normally see or don't think we're going to see anymore. Let's see, moving to our next slide here. There should be a full range of motion of the knee with normal alignment. Limited knee flexion may be caused by abnormalities of the quadriceps. Laxity of the knee joint points to a potential tear in the anterior or posterior cruciate ligament. The knee is palpated on either side of the patella to assess for tenderness, swelling, or bogginess. The patella should not move when it's palpated. Slight movement only because of you're moving it, but it should not move. Tenderness, warmth, and bogginess over the knee can indicate a synovitis, sprain, or torn meniscus. Tenderness, swelling over the tibial tubercle can indicate Osgood-Schlatter disease, All right, finally, we are looking at the feet. The feet and ankles are inspected and palpated for position, alignment, range of motion, and any visible swelling or deformities. In newborns and infants, foot position and alignment are inspected. And let's see, for older children, you want to look for that club foot, a rigid deformity involving muscles, tendons, and bone, or if a child had club foot that was repaired, you want to look for any scars or have any information about that. You also might be looking for the ligaments supporting the longitudinal arch that may be causing flat-footedness. They're lax ligaments. And so you'll look for a convex medial border of the foot, and it could be permanent or it can occur only when the child bears weight, so their feet kind of fall forward. You'll palpate the ankle for swelling, tenderness, range of motion. You'll want them to show you their full range of motion, and any limited range of motion accompanied by swelling, redness, or tenderness, which could indicate juvenile rheumatoid arthritis or other serious conditions like osteomyelitis. You'll want to look for symmetrical, painful swelling of the ankles and feet, which could also be caused by sickle cell crisis. All right, so here's a quick case study. If you have a previously healthy 12-year-old saying she has some right knee pain for 3 weeks, she's been playing basketball, running track, denies any trauma, describes increased pain when running or jumping. So what are the questions you're going to ask this child when she comes into the health office? What could you think might be the most likely diagnosis? And what are the next steps that you would want to take in managing this child's case? So here is the 90-second musculoskeletal screening examination. You'll want to note this. This is the participation sports musculoskeletal examination. This helps you find previously undetected musculoskeletal conditions and to prevent injury. And so you want them to stand facing you, look up and down, left to right, touch the ears and shoulders. Hold their arms outstretched at their side. Lift them as you provide resistance to them. Raise their elbows at the side, 90 degrees, like chicken arms, and then rotate hands backwards. Hold arms down in front of their body. Flex their elbows so that their hands are straight. Rotate hands face up and down. Spread their fingers and make a fist. Stand on one leg bent at the knee and then repeat on the other side. Walk like a duck, waddling. Stand with their back to you, with their knees straight, and bend over, touch toes for the Adams bend over test, forward bend test, and then stand on their tiptoes and then stand on their heels. And the goal is just to look for those undetected musculoskeletal conditions. So these are the 10 things that you can do here, the 90-second test that is your quick down and dirty when you're in your health office. That was more of a well child type of thing, but it could be also used for indicating any kind of deeper dive into any of those areas where they were not normal findings. All right, so assessing the motor function, that's an essential portion of the musculoskeletal examination. This includes looking at muscle tone, strength, size, and assessment of those involuntary movements. Muscle tone, movement, and posture are routinely evaluated in all the way through young childhood and into adolescenthood. But you want to note that there are some things that happen in young children. So if you're a high school nurse, you may not be seeing as much of this. Although if you are working in an SH program or a program with children that have motor deficit disease disorders, diseases and disorders, things like that, or congenital disorders that include musculoskeletal issues, you may see some of these things. So, for example, you may see issues with muscle tone. Muscle tone, which is the state of partial contraction of the muscle while at rest, is assessed by passive range of motion. Muscle tone changes with myelination and development of the brain, the cerebral cortex. Normal muscle tone shows a mild degree of tension while at rest, meaning you get to hold your head up, right? And you kind of can hold your arms in your lap. All of that is a mild tension. And it's evaluated by looking at the child in a resting posture. It's looking at upper and lower extremity tone, at head control. Tone is assessed for flaccidity or hypotonia, rigidity or spasticity, which is hypertonia, and can vary between the upper and lower extremities in terms of the amount of each of these. You can be more hypertonic in the uppers and less hypertonic in the lowers. Assessment of the general muscle tone is done first by observing the child in a resting state to evaluate the overall posture. And then you will look at the head and extremities, and you will look at abnormal positioning of the head or extremities indicates a neurological dysfunction. Decreased muscle tone or hypotonia is seen in genetic disorders such as Down syndrome, trisomy 13, and other developmental disabilities such as cerebral palsy and congenital hypothyroidism. Hypotonia is also seen after a CNS infection. So if they had some kind of insult to their central nervous system, including encephalitis and meningitis, or a traumatic brain injury. Hypertonia, which is increased muscle tone, spasticity, rigidity, persistent primitive reflexes, delayed in normal motor skill acquisition. That can be seen in children with upper motor neuronal lesions, such as cerebral palsy, and in other genetic metabolic disorders that damage their central nervous system, any types of insults in that way. Abusive head trauma can also lead to motor dysfunction, spasticity, cerebral palsy, and quadriparesis. Each of these slides goes over each of these: hypotonia, hypertonia, and motor function. So both upper and lower extremity muscle size and strength are evaluated with motor function. Muscle weakness is the most common presenting symptom of the neuromuscular diseases. Muscle strength is graded on a scale of 0 to 5, and muscle symmetry is also assessed. So you will see that when you're assessing the muscle size, you're going to look at muscles for enlargement or contractures or atrophy. And then you can measure using your tape measure. If you were going that deep, you can measure the circumference of the upper and lower extremities and then compare sides and see whether or not the right side and the left side match. And enlargement of the calf muscles occurs in Duchenne's muscular dystrophy. So that would be a sign of potential Duchenne's in a child if you were assessing to that level. Looking at the muscle strength grading, so you will use that 0 to 5 rating scale there. So muscle strength in the lower extremities is looked at in all children, and when you're evaluating it in children who are ambulatory, so older children above infants, you're going to assess for what's called the grower sign, which is seen in children with myopathies. This is when they have muscle weakness of the extensors of the hips, and when they attempt to stand up from the floor. The child first sits up, then shifts his or her body weight to the hands, then the knees, and then uses the hands and arms to climb up their own legs to stand. So we're going to go ahead and take a quick peek at this. This is called the grower's sign.